Hello everyone, this is Dr. Alsati and I'm sharing with you one case done last November. This is a one-eyed patient who's lost his eye after a complicated cataract surgery a few years back somewhere else. I noticed that as I was doing my initial capsulotomy that the lens seemed to be slightly shaky. The green arrow shows the movement of the cortical cataract as I was doing this. So I decided to use a cystotome to reduce the stress on the zonules. Yet you could see how the lens shook as I was doing this. And with the use of microforceps, and this is a true lifetime speed, I managed to do a circumferential curvilinear capsular access. Notice here that I'm holding the eye with the left hand. This case was done under topical anesthesia. And I would like to stress on the importance of doing this as slow and as careful as possible, because this is very crucial to have a perfect circular anterior capsulotomy to continue with the procedure smoothly. After this point, I was able to do a lens separation instead of hydrodissection. This is just manual separation. I use the cannula and do this 360 degrees, separating the anterior capsule from the lens without injecting any fluids or viscoelastic, and I even go through the paracentesis to do the subincisional area. I decided to use the iris hooks to suspend my lens. Hence, I did not hook anything with the hooks yet. I'm injecting now vision blue just to see the edge of my anterior capsule better, so I won't go fishing. Now, I just would advise to attach the iris hooks and do not pull them back, trying just to push the plug to where the hook has stopped rather than pulling on the anterior capsule. Otherwise, you might develop an inadvertent anterior capsular tear, which is not the best thing to happen at this stage. Notice here that I was able to do my grooving. The lens seemed to be really stable. Now my irrigation bottle is not more than 80 and my torsional power is at maximum, and my manipulation is within the bag as minimum as possible. I've decided to use the fourth hook, and at this time it will be under the main incision, just holding the capsular bag. So all four hooks now are holding the capsular bag. The rest of the procedure will go so smooth because this is already you have reduced the instability and the lens shaking. I'd like to work within the bag rather than bringing the lens anteriorly, and doing as slow as possible, gentle rotations, phaco chop technique. Now, this was a bulky lens. It needed a little more power than I expected. Yet, however, most of it was smoothly emulsified and aspirated. At this stage, I wasn't so happy and confident about the posterior capsular situation. So I injected dispersive viscoelastic and tested it, and I pushed the lens. I found it to be free. So I went ahead and continued my phaco. I will re-inject viscoelastic as much as I need according to the situation. But as taught now, you should not get out of the eye if you think that there is a posterior capsular tear or anterior capsular tear without injecting dispersive viscoelastic. So I was happy with the posterior capsule. I'm injecting my CTR. Then a multi-piece lens is chosen. Now I advise that you should not rotate this lens at all at this point. Here I decided to do an optic capture technique. So I will release the capsular bag from the iris hooks and attach the hooks to the iris, push the trailing haptic inside, and instead of using a aspiration tip, I'm using a Simcoe, which is more controllable and flatter. I enlarged one of my paracentesis sites and removed the cortex smoothly. Then the hooks are explanted gently. An air bubble is injected and 2 stitches were taken just to make sure that there will be no pressure change. And voila, this is the end. Thank you for watching.